Hello everyone. Today we are going to discuss a few things about gout or gouty arthritis. So what is gout? So gout is an inflammatory arthritis which is associated with an increase in uric acid level in blood and deposition of sodium urate crystals inside the joint space. High level of uric acid in blood or plasma leads to an increase in uric acid concentrations inside the synovial fluid, and this uric acid gets deposited at sodium urate crystals, leading to inflammation of joints and inflammatory arthritis, which we know as gout. Considering uric acid, we know that it is the end product of all purine metabolism in our body. There are certain factors in our body that increase the uric acid level in blood, and then there are other factors that are constantly trying to reduce that uric acid level in blood. Now, uric acid can increase in blood due to number one, de novo synthesis of purine. Purines get metabolized to uric acid, contributing to the plasma concentration of urates. Now, there are again a lot of foodstuffs that contain large amount of purines. For example, red meat, wine, seafoods, etc. And dietary intake of these foodstuffs can also contribute to high purine levels as well as high uric acid levels in blood. So while these factors are trying to increase the uric acid concentration in blood, the factors that are trying to reduce the uric acid concentration are primarily elimination via kidney, which accounts for 66% excretion of all uric acid in our body. The rest of the uric acid is handled by intestine, which accounts for 33% of total uric acid removal. Interesting point to note here is that we as primates lost our capacity to synthesize the uricase enzyme that converts uric acid to allantoin a long time ago, about thousands of years ago. Now, the significance of this is not very clear. Probably the presence of uric acid provides some evolutionary advantage to us humans. It has been argued that uric acid has some powerful antioxidant activity which may prolong the life in case of humans, and some also think that increased uric acid levels in human can help maintain blood pressure in times of very low salt intake. Okay, from that understanding of uric acid balance, let's try to learn why uric acid levels can be increased in some persons. So it mainly depends on two factors, whether there is increased production of uric acid or whether there is decreased elimination of uric acid. In some persons, there are increased production of uric acid, which may be due to increased purine synthesis de novo due to genetic factors like some problems with hypoxanthine guanine phosphoribosyl transferase chain or phosphoribosyl pyrophosphate synthase overactivity. Other common scenario where there may be increased production of uric acid may involve increased turnover of purines due to myeloproliferative disorders like polycythemia vera or lymphoproliferative disorders like leukemia or other disorders like carcinoma or severe psoriasis. In these cases, there are more and more cellular turnover leading to more and more purine generation, which ultimately gets degraded into uric acid that increases in blood. Persons with such problems are generally known as overproducers for uric acid. Coming to the other scenario, some persons may have impaired excretion of uric acid. These persons may be suffering from chronic renal diseases, or in case of drug therapy like thiazide diuretics or low dose aspirin, which can reduce uric acid excretion. Persons suffering from hypertension, lead toxicity, or persons suffering from primary hyperparathyroidism or hypothyroidism, etc. Such persons are also known as under-excretors for uric acid. In this context, let's also remember that the normal levels of uric acid in males are between 3.4 to 7 milligram per dl, while in females the value is a bit lower, that is between 2.4 to 6 milligram per dl. Anything above that will fall into the category of hyperuricemia. Okay, so let's understand the pathophysiology of gout. So we know here there is an increased level of uric acid in blood, and that ultimately leads to increased concentration of uric acid in the synovial fluid as well. Increased uric acid level in the synovial fluid leads to deposition of sodium urate crystals inside the joint space, which leads to an inflammatory reaction. Inflammation of the joint space at the synovium leads to elicitation of inflammatory mediators. One particularly important inflammatory mediators in this scenario would be interleukin 1 beta. Now, these inflammatory mediators leads to local recruitment and infiltration of WBCs. These leukocytes now start phagocytosing the urate crystals in the joint, and that leads to release of further inflammatory materials from the WBCs, including lactic acid, lysosomal enzymes, and other chemokines. Particularly this lactic acid, it decreases the pH of synovial fluid and makes it more acidic. And in more acidic pH, there is even further deposition of uric acid crystals. So again, further deposition of uric acid crystals lead to further inflammatory reactions, and again a fresh round of chemotaxis and infiltration of WBCs. So this cycle continues on and on. So what are our treatment goals in management of hyperuricemia or gout? First of all, we have got to take care of that acute inflammation and provide symptomatic relief to the patient, which can be done primarily by non-steroidal anti-inflammatory drugs. Colchicine is a traditional and effective medicine that can also be used for the management of acute symptoms of gout. And obviously, we have got glucocorticoids, which can very quickly control that inflammation. Secondly, we can try and reduce uric acid synthesis, which is one of the mainstay treatment of chronic gout. For that, we have got allopurinol and febuxostat, both of which are xanthine oxidase inhibitors. Finally, another option is there, that is to increase uric acid excretion with help of drugs like probenecid, sulfenpyrazone, and benzbromarone. Considering the clinical features of acute gout, it is more commonly seen in men compared to women, and it generally starts appearing in middle-aged persons. Onset is sudden, with pain, swelling, and redness of the metatarsophalangeal joint of the great toe. It can be precipitated by dehydration or intake of high amount of purine-rich foods, or by use of diuretics like thiazides. In around 25% cases, joints other than the first metatarsophalangeal joint are affected, like ankle, knee, other metatarsophalangeal joints, and even fingers, particularly in elderly. So let's learn about the treatment of acute gout. As I've already said, colchicine is a traditional and effective medicine that has been used for around 500 years now for management of acute symptoms of gout. It is an alkaloid that is isolated from the plant Colchicum autumnale. It has specific action in these acute attacks and provides dramatic relief. The dose of colchicine is orally 1 milligram tablet immediately given stat, which may be followed by around 0.5 milligram every 6 to 12 hourly till the pain is relieved or intolerable gastrointestinal symptoms appear. So let's try to understand the mechanism of action of colchicine. This is a very important question. So we already know that in acute gout what happens is that there is hyperuricemia, which leads to increased uric acid concentration in synovial fluid, leading to deposition of urate crystals in the joint space. That causes joint inflammation and leads to chemotaxis and infiltration of leukocytes. These leukocytes again phagocytose the urate crystals and cause release of lactic acids, enzymes and chemokines, which reduces the pH of synovial fluid, which again leads to further deposition of urate crystals in the joint space, and the cycle continues. Colchicine is important in that context that it tries to break this vicious cycle. Colchicine, it actually binds to the microtubular receptors of leukocytes and acts as a spindle poison. This causes loss of movement or prevents chemotaxis of the WBCs, and thereby it inhibits the leukocyte infiltration inside the joint space. As there is no leukocyte infiltration inside the joint space, there is no further phagocytosis or further reduction of pH of the synovial fluid. So what happens that effectively that vicious cycle of repeating inflammation is prevented or stopped. So thereby colchicine exerts anti-inflammatory action in this case. However, colchicine has its own share of serious adverse effects. The most common ones include severe colicky abdominal pain, nausea, severe vomiting, and diarrhea, because the drug is a serious gastric irritant. Some infrequent or rare adverse effects that can be seen with colchicine, particularly on long-term use, include loss of hair or alopecia, blood disorders, and motor weakness or motor paralysis. Other commonly used drugs used for management of acute gout includes obviously the non-steroidal anti-inflammatory drugs like naproxen, which can be given 750 mg as a starting dose, followed by 500 mg twice daily orally. Other than that, the common anti-inflammatory agent diclofenac can be given 100 mg starting dose, followed by 50 mg twice daily oral dose. And finally, we can also try indomethacin, though it is less acceptable to the patient or less tolerated. The dose of indomethacin would be 75 mg at the start, followed by 50 mg thrice daily. In very severe cases, we can also opt for glucocorticoids. Oral prednisolone can be given in a dose of 40 mg daily for 3 to 5 days, or we can also give a single depot injection of intraarticular triamcinolone in a dose of 20 to 40 mg. Coming to the treatment of chronic gout, here we have got some uricosuric agents firstly. These are the drugs that actually increase the uric acid excretion. One of such drugs is probenecid. Before we go on to the mechanism of action of probenecid, it will be helpful to understand how uric acid gets eliminated by the kidney in the natural way. Uric acid enters from blood to the renal tubules via two main processes, one of them being glomerular filtration, the other is tubular secretion. When uric acid now appears in the urine, majority of it gets reabsorbed by the proximal convoluted tubule of the kidney with help of several transporters. Notable transporters among them are URAT1, GLUT9, and organic anionic transporter 4. Now, probenecid, it competes with uric acid for the same set of transporters, and thereby it inhibits uric acid reabsorption from the urine. This increases uric acid excretion in the urine and thereby lowers the level of urate in blood. The other uricosuric agents that can act by similar ways and help in the elimination of uric acid via urine are sulfenpyrazone and benzbromarone. Now, considering the agents that decrease uric acid synthesis in the body, they are primarily xanthine oxidase inhibitors. Examples of such drugs are allopurinol and febuxostat. Regarding the mechanism of action of allopurinol, let's again go back first to the synthesis of uric acid. Purines in our body are first metabolized into hypoxanthine, and this hypoxanthine, under the influence of the enzyme xanthine oxidase, is converted into xanthine. Xanthine is again acted upon by the same xanthine oxidase enzyme into the final metabolite uric acid in human body. Allopurinol is a xanthine oxidase inhibitor. It competitively inhibits xanthine oxidase, that means it is a reversible inhibitor of xanthine oxidase, and it also has a fairly short duration of action with half-life around 2 hours. However, more importantly, allopurinol itself gets metabolized by the same xanthine oxidase enzyme into alloxanthine. This alloxanthine is a far more stronger inhibitor of xanthine oxidase. It non-competitively or irreversibly blocks the enzyme, and its half-life is also longer, around 24 hours. Alloxanthine is the primary xanthine oxidase inhibitor inside the body. Inhibition of this xanthine oxidase enzyme therefore prevents the formation of uric acid in the body and thereby lowers the plasma urate levels. Hypoxanthine and xanthine are all water soluble and they are easily cleared by the kidney. Regarding the adverse effects of allopurinol, the most common adverse effects of allopurinol are the allergic reactions, which include skin rash, fever, malaise, muscle pain, etc. Among the less common adverse effects, we have got gastric problems, headache, dizziness, nausea, etc. However, the most dangerous and rare adverse effects of allopurinol is Stevens-Johnson syndrome, which is also a life-threatening problem. Finally, very rarely, allopurinol can cause liver dysfunction also. Now coming to a very important question, that is why non-steroidal anti-inflammatory drugs are advised while starting treatment with allopurinol. Now allopurinol, it inhibits the synthesis of uric acid and thereby lowers urate concentration in blood. If there is decreased uric acid concentration in blood, there will also be decreased uric acid concentration in synovial fluid. So decreased uric acid levels in synovial fluid leads to shedding of uric acid crystals from the gouty tophi in the articular cartilages. This leads to fresh deposition of uric acid in the joint space, which leads to again joint space inflammation and subsequent precipitation of acute attack of gout. So to prevent or manage these intermittent acute attack of gout while continuing treatment with allopurinol, we need to give NSAIDs for at least the first few weeks and thereby prevent the acute symptoms. Regarding other xanthine oxidase inhibitors, febuxostat is a newer drug. It is a non-purine xanthine oxidase inhibitor, which is preferred in patients who have history of allergic reactions to allopurinol. One recent advance in the treatment of gout is rasburicase. Rasburicase is a recombinant uric acid oxidase. Now, you probably remember that uric acid oxidase, primates do not have that enzyme. So, rasburicase being a recombinant uric acid oxidase converts uric acid to final metabolite allantoin and thereby it decreases blood uric acid levels. Rasburicase is actually preferred in overproducers for uric acid, like in people who are receiving chemotherapy for leukemia or lymphoma, or in situations like tumor lysis syndromes. So that would be all for today. Thank you all. Until next time.